Hello everyone and welcome back. Today we are going to be studying psychotic disorders. So I try to include everything you need to know at a student level, final year for psychotic disorders. But if there is anything that I missed that is important, please let me know in the comments below. Okay, so to start off, here is a basic breakdown of today's presentation. Just other psychiatric disorders as well as antipsychotic drugs and their side effects would be covered in a separate presentation because this video got a little bit too long. Okay, so an introduction to schizophrenia. Schizophrenia is a relapsing and remitting pattern which is defined by observed signs of psychosis. It is a group of disorders with heterogeneous etiology, which means that this leads to variable clinical presentation, response to treatment, and course of illness. Despite the variability, schizophrenia does have fundamental features across the board, which is first described by Dr. Eugene Bleuler. Sorry if I am butchering this name, but I'm very bad with pronunciation. So, Bleuler's 4 A's. The A refers to affect, ambivalence, autistic isolation, as well as associations. Next would be the onset, or rather epidemiology. So, the prevalence of schizophrenia is quite equal between males and females. The ratio is about 1:1, although their presentation and onset differs slightly. In males, they usually present a bit earlier, from about 10 to 25 years of age, whereas females usually present between 25 to 35 years of age. If a patient presents with signs of schizophrenia above 45 years old, that is known as schizophrenia of late onset. So factors that increase mortality are namely that of medical illnesses as well as suicide. So medical illnesses, if the patient simultaneously has cardiovascular disease, diabetes, obesity, HIV, or any complications of cardiovascular disease, there is an increased rate of mortality there. And suicide mortality, I think that's quite self-explanatory, but about 10 to 38% of schizophrenic patients eventually end up committing suicide. The risk is greatest during the first year after diagnosis. Under stages of schizophrenia, it is generally divided into 4 stages, which represent the natural progression of the illness, from stage 1, where there is only risk factors present, so the patient is asymptomatic. These risks include a genetic vulnerability and environmental exposure, early childhood behavioral and cognitive problems. At that stage, there is no known interventions. Then in stage 2, this is known as the prodromal stage. It is characterized by changes in thought, social isolation, and impaired function. The intervention appropriate here would be cognitive behavioral therapy, family support, and supplementation with polyunsaturated fatty acids. Stage 3 is the onset of psychosis. This is characterized by positive, negative, and cognitive symptoms. The intervention appropriate at this stage would be pharmacological and psychotherapeutic. In stage 4, that is known as the chronic disability stage. It is characterized by social disability, which includes your unemployment, homelessness, and incarceration. There could be occupational functional disability, as well as presence of psychiatric deficits. In this stage, there's an increased rate of suicide, an increased rate of obesity or smoking, or any other harmful or addictive behaviors. So not all patients progress to this chronic stage. Therefore, it is important to diagnose schizophrenia and then intervene as early as possible. Then onto the diagnosis of schizophrenia. At our medical school, we use the DSM-5 diagnostic criteria. I know in other areas They use the ICD-10, but I'm not familiar with that criteria. So in this presentation, we will only be covering the DSM-5. So the DSM-5 criteria consists of criterion A to F for schizophrenia. Criterion A, okay, so you have to meet all of these criteria from A, B, C, D, E, F in order for the patient to be diagnosed with schizophrenia. So criterion A states that 2 or more of the following symptoms must be present for a significant portion of time during a 1-month period, and at least one of the symptoms must be hallucination, delusions, or disorganized speech. The other 2 symptoms in criterion A are disorganized behavior or catatonic behavior and negative symptoms. Criterion B is social and occupational dysfunction, and criterion C refers to the duration. There should be continuous signs of disturbance for 6 or more months, which include the 1 month of symptoms meeting criterion A. Criterion D is the exclusion of schizoaffective disorder or depression plus bipolar disorder with psychotic features. Criterion E, not due to substances or other medical conditions, so those have to be excluded. And criterion F, if there is a history of autism spectrum disorder or communication disorder of childhood onset, this patient additionally needs prominent delusions or hallucinations in order for them to be diagnosed with schizophrenia. Because patients with ASD or communications disorder of childhood onset can look very similar to schizophrenia, therefore they have to have prominent delusions or hallucinations. Under the clinical features, I separated or grouped the clinical features into positive, negative, cognitive, mood, neuromotor, and other symptoms. So the most pathognomonic or important symptoms for schizophrenia would be the first 3 groups. In positive symptoms, these include delusions, hallucinations, disorganized speech and behavior. In negative symptoms, those are the 5 A's. A standing for affective blunting, alogia, avolition, anhedonia, and asociality. Under cognitive symptoms, that refers to an impairment in attention, memory, as well as executive function. Mood symptoms refers to depression, hopelessness, suicidality, anxiety, agitation, or hostility. Neuromotor symptoms refer to catatonia, stereotypic movements, dystonia, hypokinesia, or dyskinesia. Other symptoms include loss of insight, impaired judgment, poor self-care, or an unkempt attire or look, and inappropriate behavior. So, the differential diagnosis for schizophrenia includes delirium, substance intoxication or withdrawal, other medical conditions such as SLE, thyroid, Cushing's syndrome, HIV, syphilis, liver failure, or renal failure. Other psychiatric disorders include MDD, bipolar, and OCD. The prognosis for schizophrenia. So with all schizophrenic patients, about 30% of them would go on to live relatively normal lives on medication, about 20% would have a good outcome, and about 50% of all cases would have a poor outcome. So there are factors that would contribute to a good prognosis, sometimes also known as protective factors, and then there are factors that contribute to a poor prognosis. Protective factors would include if this is a late onset schizophrenia, if there's obvious precipitating factors, an acute onset, good premorbid functioning, mood disorder symptoms, family history of mood disorders, if the patient is married, if the patient has a good support system, or positive symptoms. Poor diagnostic or poor prognostic factors would include young onset, no precipitating factors, insidious onset, poor premorbid functioning, withdrawn or autistic behavior, single, divorced, or widowed, if there is a family history of schizophrenia, if the patient has poor support systems, negative symptoms, neurological signs and symptoms, history of a perinatal trauma, no remission in 3 years despite treatment, or multiple relapses. In the management of schizophrenia, the basic structure is that of biopsychosocial. Under biological, that includes hospitalization, pharmacological with a typical or atypical antipsychotic, and management of side effects. Under psychological and social, that would be psychoeducation, social skills training, family orientation, as well as psychotherapies. Under pharmacological, these would go into greater detail about the typical and atypical antipsychotics. So the thing to know about pharmacological treatment is that it's rather a symptomatic treatment and for decreasing the relapses, which, impacts the mortality and chronicity of schizophrenia. It is important to know that it's non-curative. So the indications for pharmacological intervention would include psychotic disorders, dementia, or augmentation in MDD, OCD, as well as tic disorders. A little bit more about pharmacological management continued. So in pharmacological management, it is split into the acute management of acute psychosis, as well as then the chronic management. In a patient with acute psychosis, you can choose to chemically restrain if there is any signs of aggression. That would be your lorazepam 2 to 4 milligrams IMI plus your IMI acute onset antipsychotic. Usually that would be your haloperidol or olanzapine. The other ones are ziprasidone and the other one that I can't pronounce, but usually we use haloperidol. Then, after the patient has been stabilized from the acute psychosis, you would have to query whether admission is warranted, whether admission is essential. Okay, and then from there you would manage. Then there are some depot preparations for antipsychotics. Do not use these until there has been a response to your per-hour treatment, and you should start with the lowest possible IMI dose and then increment slowly. The indications for a depot preparation would be a poor adherence to per-hour treatment or a difficulty remembering in taking their medications or any other situation where they would not be able to take per-hours. These would include the first three that I can't pronounce, and then most commonly we use at our institute risperidone. Okay, so that is all for today's presentation. There will be more detail about the antipsychotic drugs and their side effects, as well as other psychotic disorders, because I know we only covered schizophrenia in today's presentation. So thank you, and I hope that this really helped you. Good luck for your exams, and I know you will do well. Okay, please leave your comments in the comment section below if you have any suggestions or any complaints, any suggestions. Okay, see you next time. Bye.